We're going to be discussing about schizophrenia, and today the learning objectives at the end of this presentation, we all should be able to schizophrenia and discuss clinical features and treatment of schizophrenia. So what is schizophrenia? Schizophrenia is a Latin word that schizo means to split and phren means the mind. So it is the split between the mind and intellect, and it's a complex heterogeneous syndrome that is characterized by disorganized thoughts, delusions, hallucinations, impaired psychosocial functioning. So at the right-hand side, you can see the structure of a brain or of a healthy brain. And on my left-hand side, you can see the schizophrenic brain, how it looks like. So what is the epidemiology? How does the epidemiology looks like? So here, schizophrenia its onset mostly is in late adolescent and early adulthood, and the peak age in males is 20 to 38 years, and for females it's 26 to 32 years, and it occurs more in males than in females. So what are the risk factors? Risk factors are the factors that predispose one to getting the disease, that is schizophrenia. So one is family history. We have 6.6% of all individuals with mental illness have a first-degree relative with the disease. And also another risk factor is some pregnancy and birth complications, e.g. malnutrition, or exposure to toxins or viruses that might impact brain development. And the third is psychoactive or psychotropic drug abuse. This is cocaine, heroin, marijuana, also commonly known as bang. So what are the causes? What causes schizophrenia? So there are like 4 different models that try to explain the pathophysiology, also known as the cause. So one is environmental factors and immune disorder model. So here, this schizophrenia may be triggered by environmental events, example, viral infection or immune disorders that affect the brain or how the brain develops. The second one is developmental method model. So this is where if critical periods in the development of neuronal cells is adversely affected, now you can get schizophrenia. So the third one is ecological model, where we have external factors involving social, cultural, physical, and maybe individual space, economic status, and racial status can predispose you to get schizophrenia. The fourth one is genetic model. So again, in the risk factors, we saw that 6.6% of all individuals with mental illness have first-degree relatives with the disease. And then now the fifth one is transmitter abnormality model. Now here, what neurotransmitters in simpler terms are like chemicals that are produced by cells to help them communicate. Now, in this, the reduced example of neurotransmitter is dopamine. So when you have a reduced dopamine levels in a region of the brain we call the mesocortical region, now you get negative symptoms that we will see later on in the clinical presentation. And if you have high levels in another region we call the mesolimbic system, then you're going to have positive symptoms. Now, in the clinical features, again, I've told you, we have the positive symptoms that occur due to increased levels of dopamine, the neurotransmitter, in the mesolimbic system. So what are these positive symptoms? We have delusions, we have disorganized speech, we have disorganized behavior, and we have hallucinations. So what are delusions? Delusions, these are firmly held ideas that a person has and clear evidence that isn't true. So they occur approximately in 90% of the individuals with schizophrenia. And there are several types of delusions that you might have. So first, type of delusion, you have delusions of persecution. So these individuals, they believe like they are out to get me, e.g. the Camaras are trying to poison me with radioactive material delivered through my tap water. Another type of delusion we have is delusions of reference. So a neutral environment is believed to have a special or personal meaning specifically for them. For example, if they went and saw a billboard or maybe news, some piece of news in the television, they believe that that piece of information is specifically meant for them or for them to hear. And then we have another type of delusion called the delusions of grandeur. This believes that these people are famous. They believe that they are famous. So they might tell you an example like, yo, I'm coming tomorrow. And you ask them, who am I? And they tell you, I'm coming tomorrow, I'm Jesus. So, things like that. The last type of delusions of control is delusions of control. Now they think that these are the beliefs that their actions or thoughts are being controlled by a third person, like another person in a third person, yeah. So the other type of positive symptom is hallucinations. Now these are sounds or any other sensations experienced as real when they only exist in the patient's mind. So they can involve an array of like all the five senses, but the most common with schizophrenia is hearing voices, and they tend to worsen when the individual is alone. So the other one in positive, the other positive symptom is disorganized speech. So where the individual with schizophrenia have trouble concentrating and maintaining a trail of thought, which may come off as a rapid shift in topic. Like they can't talk about one topic and finish, go to the next. They rapidly like shift topics. The second is they respond to questions with unrelated answers. They use made-up words that only have meaning to them. They are very repetitive and they have meaningless, like rhyming words. And the last one of the positive symptoms we have is disorganized behavior. So the individual with schizophrenia have impaired ability to take care of themselves, work and interact with others, which appears as inappropriate emotional response, decline in overall daily functioning, and lack of inhibition and control impulse. Sorry, excuse me. So sorry about that. So let's discuss about, kindly mute yourselves, guys. So we background noise.
Go ahead, Maryanne.
Okay. So negative symptoms. Negative symptoms, again, we have decreased emotional range, poverty of speech, and loss of interest in drive. So cognitive, we also have cognitive symptoms, which are neurocognitive deficits in working memory. They have a reduced attention, and they have also executive function, such as their ability to recognize and abstract. So they find it hard to understand and maintain interpersonal relationships. So, and then they have mood swings. So these patients often seem cheerful or sad in a way, and most of the time they're depressed. So we have two types of schizophrenia. So paranoid schizophrenia, which is the most common type, and presents with hallucinations and delusions. Speech and emotion may be unaffected, and they're usually at very high risk of suicide. And the second type is disorganized schizophrenia, which is characterized by disorganized behavior, e.g., disorganized thoughts. So here, it develops mostly between 15 to 25 years. So how do we diagnose or how do you know like a patient, like a person has schizophrenia? We use a criteria called the DSM-5, which we will see later on in this presentation. So how do you diagnose? So either the two or more symptoms must have been present over the prior month for a significant period. Either now you have two or more symptoms, like either the positive or the negative. You might have hallucinations, you might have delusions, you might have disorganized thoughts, you might have disorganized speech, or one or only a patient has one symptom if the symptom is delusion and providing running or two voices conversing. Now, most of the patients say that they're hearing voices. Now, if the patient is hearing voices, then now they're diagnosed to be having schizophrenia. So how do we manage patients with schizophrenia or individuals with schizophrenia? So what is the goal of management? The goal of management here is to achieve best mental function. And the second one is to use the biopsychosocial model. Now, what is the biopsychosocial model? Now, this is where we try and understand a disease with respect to biology, psychology, and the social context. Now, we cannot only describe a disease to be only caused by maybe biological causes or psychological causes or social context. All these factors.
Hello, Maryanne.
Yes.
May I interrupt you? Can you go back from biology, where you're explaining from biology? Yes.
Biology. Oh, here. Okay.
Yes.
Okay, so I was saying that I was discussing the goals of management. So here we have the goal here is to achieve best mental function and to use the biopsychosocial model to try and manage this disease, schizophrenia. So I was saying that a disease, you cannot only understand a disease by maybe biological terms only, psychological or social context. It's an interplay of all these factors. So, for example, let's take an easy case like blood pressure. So, blood pressure, of course, the biological part of it, now you know that you have increased pressure, like you have maybe reduced the lumen of your blood vessels is reduced, maybe by fat deposition and all that. So you have increased pressure. Now that is what we call the peripheral vascular resistance. So that is the biological part of blood pressure. For the psychology part of blood pressure, when you have stress, your blood pressure tends to go high. What are the behaviors that feed into high blood pressures and all that? And then for the social context of it, now, what is the family background? Do you have family history of the disease? What are the cultural and tradition, social, economic status, education? All those factors come into play when you're trying to define a disease, and also affects how you're going to manage the disease. So here in the management, we use pharmacologic, basically, like we use chemical agents, and also we can use other things that are not necessarily chemicals to try and manage this schizophrenia. So in order to understand like how far, like the mental illness, we need to like, I'll give you a very brief history. Now, the history of mental illness is very rich, and I don't think I'll do it justice, but with interest of time, I will try to like paint you a mental picture so you can be able to understand like how far, like where the mental illness, were the attitudes back then in the 15th century up to now, and what are the attitudes now, and what things have changed. So it is quite interesting. So in the colonial America, so many attitudes of early colonists towards individuals with mental illness stemmed from European attitudes developed over centuries. So we have an example of a document written in the 15th century in Europe called The Witch's Hammer, which stated that demons representing the devil could invade the souls of individuals and result in deviant acts, and these people were now punished by persecution or burnt to death. So you can actually now see why stigma comes into play with mental illness. Example, what we're dealing with today, schizophrenia. So, but later they discovered that individuals with mental illness were not just passive recipients of these spirits, but rather they had control over these impulses, and now were not viewed as they were now viewed as individuals, opposed to prior situations where they were seen as societal problems. So fast forward to the 1700s. So now we see now people are not being, the individuals with mental illness, example, schizophrenia, they're not now being seen as societal problems, and now they're being seen as individuals. So now there are no policies to guide on how to deal with individuals with mental illness. So in the 1700s, so there is development of general hospitals, private institutions, public hospitals for individuals with mental illness. Fast forward to the 19th century. Now I want to paint a mental picture for you. Now this is where there was industrialization. Now people are moving from farms and investing more on factories. And here now there is increased population because of the shift. And now we are having more incidences of people with mental illness. And now the government is forced to take up the responsibility of taking care of these patients. So we have now hospitals, but now the problem is there was overcrowding and poor staffing, and this caused like more asylums to be developed. So the overcrowding and now due to the overcrowding, so the staff of the asylum staff now were only concentrated on maintaining the routines, and this caused like poor outcomes and while trying to manage people with mental illnesses. So this also in the 19th centuries, this is where they developed techniques of treatment such as cognitive behavioral therapy, which I will discuss in a few. So fast forward in the 1800s, now they start using chemical and biological treatments. So and then they discovered that, hey, wait, this mental illness, I think there is a hereditary. They thought like this, there is a hereditary component to the mental illness. So now they wanted involuntary sterilization of the mentally ill. Thank God for these people called the National Committee for the Mental Hygiene that now came in and protected people with the individuals with mental illness. So fast forward to the 1948, now we have the World War II. There is less funding to the health care, because all the monies are being invested in war. So now it costs the doctors and the medical personnel to start exploring drugs that already existed for other diseases to try and use them for mental illnesses. Example, schizophrenia. Example for this disease, chlorpromazine, which was used to relax patients during surgery. It's for the pharmacists, it's an antihistamine. So now they started using such drugs, and they tried to repurpose such drugs. Fast forward to the 1952. Remember, in the diagnostic, how to diagnose schizophrenia, we talked about the DSM, specifically the fifth DSM. So DSM stands for Diagnostic and Statistical Manual for Mental Disorders. Now, statistical Diagnostic and Statistical Manual for Mental Disorder. So in the 1961, now they invested more on research, development of hospital, and public education. Then I want us to discuss something called institutionalization. Now, what is it? Now, in the asylums, most patients were treated for long periods, some weeks that transitioned into months, others also stayed there for a long time. So these people were not able to function outside that structure of the asylum. So, and there was need to deinstitutionalize them. That by creating halfway, places, community, hospitals, halfway. It's not a mental facility, and they're not completely released into the society. Now, it helped them transition from hospital back into the society. So now I want us to discuss the chemicals or drugs that are used to treat schizophrenia. Now, we have, and the major drugs we use is antipsychotics. So now, they are also, pharmacists may tell you that they are also known as neuroleptics, they're also known as major tranquilizers, and they're divided into first generation, also known as atypical antipsychotics. Examples, chlorpromazine. You remember this chlorpromazine was discovered when they were trying, during the World War II, 1948, when they were trying to find more uses of already existing drugs. Another one is flufenazine, haloperidol, all this. And the second generation, atypical, also known as atypical antipsychotics. And examples are clozapine, olanzapine, risperidone. Now, pharmacists may now go into detail and tell you the advantages of using first generation, second generation, and try and compare all that. But I will not bore you with the details, because most of us, not all people in this forum are on the medical background, but some of, maybe just to mention, the first generation, they have side effects, because now they try and remember. Now, when we were saying that, when we're trying to explain the cause of schizophrenia, we said that it is we have an imbalance of dopamine, the chemical that is these are chemical that is produced by cells to help them communicate. Now, when you have increased dopamine levels in certain brain regions, now that causes positive symptoms and another negative symptoms. Now, to try and manage this disease, now they are going to, maybe where there is low dopamine, they try and increase it. Now, this is what the first generation do. So, and the second generation also try and increase dopamine levels. So yeah, that's dealing with the negative symptoms, which is reduced speech, depression, which is going to cause suicide thoughts and all that. So here we're going to discuss my favorite, the non-pharmacological. It is my favorite because now everyone can help or can help manage this mental illness. The first one is cognitive behavioral therapy. Now, this is an intervention that aims to improve mental health, and it focuses on challenging and changing unhelpful behaviors, improving emotional control, and develop coping. They help the patients develop coping strategies to solve current problems. The second one is cognitive remediation, which is designed to improve attention, working memory, flexibility, and planning. And then the third one is social cognition training, which aids in emotional processing and reduces aggressive attitudes. And then we have metacognitive approaches, which helps the individual with schizophrenia understand how they think and how they learn. So other non-pharmacological approaches we use is we encourage the individuals with schizophrenia to seek social support. Now, this they can do by volunteering, joining clubs, and where they share with people they share common interests. We also encourage them to reduce stress. How do you reduce stress? You can do this by an array of activities, meditation, yoga, all that. And then regular exercise, we encourage people with mental illness and even we encourage all people to exercise regularly. And another thing is have plenty sleep. Now, for these antipsychotic drugs, most of them one of the side effects is they cause sedation or drowsiness. So we encourage these people to have plenty sleep, between 7 to 9 hours. And then we're also going to tell them to avoid alcohol, drugs, and things containing nicotine, like tea and cigarettes and all that. And then we also encourage them to take meals that are nutritious. So let's discuss about stigma. Now, stigma is a negative consequence of labeling that is associated with 3 components. 1, you set the person apart from others. 2, you link it links the marked person to be undesirable. And 3, rejects and avoids the labeled person. Now, what are some of the labels that are attached to persons with mental illness? In Kenya, some of them is Mogoroki, some of them Mwenda, some of them is another one is Mathare. In English, psycho, nuts, cuckoo, crazy, and all these labels, they actually are not good for persons with mental illnesses. So one of the factors that has caused the loose use of these terms, as let me call it the loose use of these terms, is maybe social media, television. Like most of the movies, if you like look how they try and paint a mental picture of a person with mental illness, they will paint them as this aggressive person, dirty, all the undesirable things you would think of. And most of us think that the things we see don't affect how we think and how we act, but it actually does. A study was done back then, and it showed that it actually even affects how clinicians tend to attend to these patients. So how do we facilitate patient recovery? Now I'm going to do this. We can do this through 4 ways. We have to give them hope. So hope refers to the belief that recovery is possible, and it usually means that the individual has actually accepted that there is a problem and has committed to changing and focusing on the positives and avoiding the negative aspects. And then the second one is healing. So overcoming in this, now they have to themselves overcome the stigma they have towards themselves for having mental illness, and regaining the regaining of self-esteem, self-respect, and control over their symptoms. So the other one is empowerment, where the internal capacity to take greater control and responsibility of oneself. And the last one is connection, where individuals reconnect with social world by filling various roles, be it employment, family, religion, all that. So what are the considerations or changes or that we may want to make in order to improve how we take care of the patients with mental illness? Example, schizophrenia. That is what we're dealing with today. So the medical providers, they must give information of the benefits and side effects of the drugs that these patients use. These are the antipsychotics, and even help them try and decide what treatment is best for them. So the other one is we have to pledge more training and mental health profession through fellowship and grants to support research relating to cause, diagnosis, treatment of schizophrenia. And third is building more community-based programs and attempt to deinstitutionalize them and help them transition into the society. And then what we are doing today is creating public awareness by creating campaigns on these mental illnesses. So, and the last one, and very important, is stop labeling individuals with schizophrenia as schizophrenic, because their identity is more than the illness. The illness should not define them, and rather be a part of them, because these people are brothers, they're sisters, they're fathers, and it's quite unfair for us to label and try and impose that label on them, which reduces them to the disease, which is not right. And if you've noticed in this whole presentation, I've tried as much as possible not to refer to them as schizophrenic or people, but I've tried to use the term people with mental illness, because that does not define them. With that, I beg to end. And the floor is open. Thank you for your time. And the floor is open to comments and questions. Back to you, Kevin.
Thank you. Thank you, Maryanne, for that presentation. It was quite informative. I was very interested about what you talked about stigma. It's what made me start this initiative of starting these talks and discussions every Saturday. The aim is to raise awareness and try as much as possible to reduce stigma, because stigma will always be there, because we always react to things we don't understand. So maybe you can't relate to someone with schizophrenia. So most people, they don't stigmatize intentionally. It just happens, but it doesn't mean that's right. It doesn't justify what's the wrong that you're doing to those people. Basically, it's yes, I appreciate you tackled the topic well. I know it was kind of a short notice, but yeah, you covered it quite well. My question is, you talked about the 15th century, something about witch's hammer or something like that, right?
Yeah. Yes.
Yeah. Do you think it's still happening in our society? In terms of people believing that schizophrenia is as a result of witchcraft, or maybe someone was possessed by demons or something like that. Do you still believe it happens in our society?
Actually, people To answer your question, thank you for your question, Kevin. And to still to answer your question, now there are myths. There are various myths that people that still hold up to date. Now, one of the myth is that mental illness is equated to spiritual or like devilish things. So I believe it still happens to date. It still happens to date, but I think with public creating public awareness and increased levels of like development of schools and everything, people are now learning, and I think compared to then, it has reduced greatly today.
I appreciate that answer. So I was taking some study about quality rights of people with people with disability, which includes people with mental health illnesses and disorders. So there was something like, they used to say the human rights were based on two principles traditionally, the social and the medical. In the medical, it's where the doctor perceives someone with a disability as someone to be fixed, like a tool to be fixed. Like you see a wheel, when you take a wheel to the a car to the garage, the mechanic will look at the car as a problem to fix because maybe something is broken. So in the medical model of human rights, the doctor views a person with a disability as something to be fixed. So do you think this is we should change this kind of thinking?
Yes, thank you, Kevin, again. So as I mentioned, we have to approach mental illness with a biopsychosocial model. Actually, when I was doing the research, I saw that there was a point, I think it was in the 1940s, where now they concentrated only, now when they started discovering the chemical drugs, they only concentrated on those chemical drugs. They ignored other approaches of treatment, which is the cognitive, which is more social and everything. And this did not have any good treatment outcomes. So to answer your question, Kevin, yes, I think that people, that management should be taken as the biopsychosocial. We should use the biopsychosocial model to try and manage the disease. Yeah.
For the response. Anyone else with a question? Also, Kerry says schizophrenics are so unpredictable in behavior, especially those who are managing their condition. They're not managing their conditions well. It can easily cause without blinking. That's why they are very well guarded mental hospitals. And as much as we would love to embrace such people into the society, reduce stigma, we should remember to be cautious. Yes, Kerry, I agree with you. I happen to have gone for my attachment in Mathare. Yes. Some of them, they're quite unpredictable. They can be violent. They can be, yes, we need to be cautious. But I think we can take an approach where maybe the person might not be in a position to make their own decision, or maybe, yes, they cannot make their own decision, but there's someone who's trusted enough. If you give them this information about how to treat them well, like they understand the schizophrenia, they understand the condition the person might be suffering from, I think we can try as much as try and make them, try to embrace them in our society, because we know as much as we in our field, we love giving people medication. That's our specialty. But I think there's a perspective of the social perspective in the healing process of this person, because if the family understands the person and you're always there for the person, I think the person would also feel encouraged, because they have someone to lean on. They have someone who's always there in their dark, in the condition we are going through. So I think as much as we should take caution, teaching people to understand them, I think it might make the world maybe kinda a better place for a person with a particular medical mental disorder to feel safe, and it might encourage them and also facilitate their healing. Anyone else with another opinion? Anyone else? The floor is open. You can raise your hand. You can type on the chat box. It's okay. And also there's a poll I'm conducting. It's yeah, you can just vote. At the end of the session, I'll give you the results. Anyone else who has a comment? Oh, there's Grace. Grace has a question. How can we factor in family members who live with an individual diagnosed with schizophrenia, considering that they have a history of violent outbursts that causes injury? Maryanne?
Yeah, thank you for the question. So I think one, we try and understand them. We try and understand that this is a disease, just like how you can have stomachache, like how you can have maybe blood pressure. This is a disease, and it's one of the symptoms is that they might actually be violent, which may lead to harm. So how to manage that? I would encourage them to encourage the individuals with mental illness to take their medications, because the antipsychotic drugs, they help actually like almost immediately deal with the symptoms, which now the positive symptoms and the negative symptoms. I think when we try and assist them adhere to their medication, now that might actually help deal with their symptoms, which takes them as close as they were to mental health. Yeah.
To add on whatever Maryanne has said, yes, if someone is correctly taking their medication, as much as the family members might be in danger because of a violent outburst, if someone is adhering to their medication, I don't think it might be a problem as such. But Maryanne talked about being institutional. Jesus.
Exactly, it's a problem.
Okay, yes. These people being put in institutions such as Mathare. For someone to be put in such an institution or an asylum, you have to maybe exhibit, you might be a danger to yourself or to your family members, or yeah, in the society in general. So I think someone with such outburst and they're not adhering to their medication may be prompted to be admitted in such an institution. So yeah, I hope I've answered your question, Grace. Anyone else with a question? And kindly, guys, keep voting on the poll I've posted, please. Yes, Grace, I can see your hand is up. Grace Mwende. Hello? Oh. Okay, so yes, I think we have learned a lot. I can see positive comments from Vero. You're saying, yeah, stigma, yeah. And if you deal with most mental health issues, may it be something as minute as maybe like anxiety, which can be overlooked, something like depression, which is affecting most youths, and suicides. May it be something like bipolar, which is not clearly understood, and people use it as a label to show them like you're being cool or something. Maybe it's like something like addiction to alcohol, which people are usually stigmatized a lot because they say it's your choice, you choose to be addicted. It's not your choice, it's a disease, and if you don't seek proper treatment, you might end up messed up, kind of. Yeah, stigma is fair, and I think all of us, you don't have to be a health professional, you don't have to be in the health profession frontline helping people. You can be someone too in your church. You can maybe stand. Hello? Okay, you can stand before your church, present something simple, whatever you know. You can start small, whatever you know, whatever you understand. You can tell them, yeah, we need to. There's something like suicides. It's all over in the news, but people don't want to talk about it. Depression. You can see people who are depressed in our society, but people don't want to talk about it. I think it's a role of everyone to take your stand and declare, like, we should battle, we should campaign for these people, because today it might not be you, but you don't know about tomorrow. Tomorrow is not promised, and I would hate to see someone in such a situation, and being stigmatized is not something good, because you want someone to be fair for you, you want someone to hear you out, you want someone to hold your hand and tell you it will be okay. But in society we live in, it's the opposite. People, like, you tell someone you're depressed, you're depressed, they'll be like, okay, sawa, unataka tufanye, or utakuwa poa, just give it time, or maybe you're suffering from, like, maybe bipolar episode, you're in the manic disorder. People wako na shida gani, huyu amerogwa, familia yao, something like that. Yeah? But if you get to understand, if you get to learn what these mental health issues and disorders, where people like us, where people like me and you, where they can function well and be part of a productive and be productive in our society. But the information is not fair, and we have to get the information out fair. And that's what I would like each and every one of the 23 of you who are in the audience today to take home. So I think I'll end my poll there. And my first question was, if I created a group where we can conduct offline discussions, allow audience to give us topics which they want us to discuss on these talks, and maybe receive is it was 100% yes for those who voted. And yes, I appreciate the support for thinking these sessions were very informative. So I'm going to post a link to the WhatsApp group in the chat box so that everyone can join. As I do that, I would like, yes, Grace, you have raised your hand. Grace Mwende. Okay. Yes, Grace. Grace Mwende. I think. Yes. Ezron. Yes. Okay, yes, you're back. I'd ask you to tell us more about your magazine which you're launching. I think, is it the third edition, or?
No, it's the second.
The second edition. Okay, yeah.
Yeah.
Tell us more about it. Maybe someone has an article they want to write. Maybe they're passionate about writing. Tell us more about it as I send the link to the WhatsApp group.
Yes, thank you. So, first of all, I'd like to say thank you to Maryanne for the presentation. It was good. And also thank you, Kevin, for running the session. So, a little bit about Planet Wizard. It's a health magazine. And what we do is share health information with the goal of transforming the health system from sick care to healthcare. And the reason why we are doing that is because they usually say that most health systems are built to respond to healthcare instead of to respond to the sick instead of like prevention. So what we do is provide healthcare information through our digital platforms, which is the website, our magazine, and also our social media pages. So we'll be having our second issue coming up this October. And we need people to write articles that are sharing health information. So you're all welcome to write if you have anything that you think might be important to the public. Yeah, so thank you so much. And have a good week ahead of you.
Thank you, Hez. So I've posted the link to the group on the chat box. You are all free to join, and also can invite your friends. I think next week we'll have another session. If I'm not wrong, I think we'll be discussing bipolar, but if you join our group, I'll tell you what we'll be discussing next week. If not bipolar, but I'm sure it's bipolar. You can think about it. I'm sure people are interested to know more about bipolar. There are a lot of myths and misconceptions in our society about bipolar. As you have learned about schizophrenia, and I would like to thank Maryanne for the presentation. It was awesome. Unless there's anyone with a comment, I would like to end the meeting there. Anyone? Dr. Kid?
Yes.
Are you still playing the guitar, or are you waiting for requests, special requests?
Maybe let me play the guitar next time during the next meeting.
It's okay.
I'll play Maryanne the guitar because she presented very well, but right now I'm not in a position to entertain. Niko mbali sana na guitar yangu.
It's fine. We understand. So next time,
I'm disappointed, Mike and Amos and who else? They're not, and David. They're not part of us. I think I got this link from.
David offered his apologies. He's held up. He has quite some reports to write, so I'll apologize on his behalf.
No problem. Also, it was nice seeing Hezron. Hezron, hi. Good job you're doing the magazine. I really loved it. I love the magazine. I love it. Also, it was nice meeting up with some of you guys. I think I last saw you so many years back. You'll be surprised at the changes that have happened to some of us. Kitambi, Nini, Wapi, Devu. But anyway,
thank you for joining us. Thank you for joining us today, Dr.
Okay.
Okay. Hezron, I say you had raised your hand. Okay. Thank you for joining the session. So you can say your goodbyes as you leave the meeting, and thank you. I hope you join us next week for a discussion. Thank you.
Goodbye.
Thank you for tuning in. Thank you, and have a great weekend ahead.